when I learned about it in Abilene, for me, just the way that my brain works and how I put things together, and I was told about just more physiology. I was kind of taught more the nuts and bolts of cardiac arrest, and then told about CCR. I was like, oh yeah, obviously. And this is something that's really just become a passion of mine. And I'm really excited to share this with you. And we'll have time for questions at the end. But if there is something that you feel is unclear, you need me to repeat or whatever, just have Wade interrupt me and we can address it right then. I don't have a problem with that at all. Hold on. Why am I having technical difficulties? There we go. Wade kind of already introduced me. I am a native Texan. I am born and raised in this wonderful state. I have moved around a little bit. I currently live in El Paso. I have been practicing athletic training for 10 years, which is kind of surreal to me right now. Some days I still feel like a baby, a young right out of school, and sometimes I feel like I've been doing this forever. I'm currently the Associate Director of Sports Medicine here at the University of Texas, El Paso. I work primarily women's basketball and golf. I have a lot of administrative duties as an Associate Director. And one cool thing I kind of do on the side as well, I'm one of the most advanced dry needlers on our staff. And so I consult and I treat almost every other sport on campus as well to treat with dry needling intervention, which I think is pretty cool, which is my other passion if you want to get me talking for an hour about. As Wade said, I was first introduced to CCR in 2015 when we did an IPE with our EMS when I worked with Wade in Abilene. And we were talking about a bunch of different stuff, heat illness and just different emergency situations. And they were like, this is how we handle cardiac arrest. And I was like, little brain explosion. I was like, this is awesome. Athletic trainers need to know this. Why do we not know this? Why are we not taught this? It's really something, it's something that Wade integrated into our standing orders and how we had our cardiac EAP. And really it's something that I will share with anyone who sits still long enough to listen to me talk about it. Learning objectives for this lecture. Generally, I want you to be able to recognize and appreciate the difference between primary and secondary cardiac arrest, describe how oxygenation, excuse me, that's the worst word, in both primary and secondary cardiac arrest and how that relates to how we choose how we resuscitate. Talk about compressions, the lack thereof, and how that affects the heart and perfusion. We're going to describe the differences between positive pressure and passive ventilation. We describe the community and EMS steps of CCR and how it applies to athletic training and how we can apply it to our everyday EAPs that we have. And then just being able to distinguish between cardiocerebral resuscitation and cardiopulmonary resuscitation. Because as passionate as I am about CCR, there are different indications where you should use CPR over CCR and things like that. And those are differences that we need to appreciate as well. A little bit about cardiac arrest in general. In the athletic training literature, most of the time it's addressed as sudden cardiac arrest or SCA. In the emergency literature that I've used mostly for this presentation, SCA and primary cardiac arrest are really the same thing. So keep that in mind. But in the athletics realm, sudden cardiac arrest is the #1 cause of death in athletics, or known as sudden cardiac death. We see it more in males and females, and more in men's basketball than any other sport. Men's basketball is only 4% of all NCAA athletes, but they are 20% of reported sudden cardiac deaths. If you add together basketball and football, that's half of all sudden cardiac deaths you see in that realm. Now, one thing that's hard, there's reporting of sudden cardiac arrest is not great. So the numbers, sometimes we see these big ranges or it's hard to have just a whole lot of accuracy, because a lot of times if they have sudden cardiac arrest, but they survive, those numbers are never reported in a way that can be tracked at this point. And then one big thing, and why it's so important to have a really good EAP for cardiac arrest, is because anywhere from 60 to 80% have no warning signs. Their cardiac arrest is the first cardiac event that they have had in their life. And so we do what we can, the literature, and working on trying to figure out how to prevent it. How can we catch those warning signs? A lot of times we do echoes and ECGs and things like that on intakes, particularly in our high risk sports. But they really are still not guaranteed to predict a sudden cardiac event. So it is really, really important to know appropriate interventions and to have a really good EAP for that. So the overall knowledge gap is really interesting, and it's kind of an overall knowledge gap, and then in athletic training, there's a bit bigger knowledge gap because we're just not aware of this in general. So our common thought is, okay, cardiopulmonary resuscitation, CPR. We know that, we got to get trained in it every 2 years, okay. We know CPR plus AED is the best intervention for sudden cardiac arrest, and really, for at least as long as I knew until I was told otherwise, it was the only intervention. There wasn't like, oh, this or that, or there was no, I didn't know there was controversy in the field. It was just, this is just what you do. But there really is another school of thought that exists, and that's our CCR. It's our cardio-cerebral resuscitation. There's a different emphasis. Plus an AED, we know AEDs save lives. Definitely have that in our EAP. But that's an alternative and a highly effective intervention utilized by a lot of EMS companies across the nation, but it's really widely unknown in athletic training, and I am seeking to fix that. When I had to do this for NATA, I had to break it down into a PICO question. So my PICO question was as follows. So our patient population are adults with primary cardiac arrest. So it's a pretty specific patient population, but it's a lot of what athletic trainers deal with. Our intervention is our cardio-cerebral resuscitation compared with cardiopulmonary resuscitation. And the main outcomes we're looking for is survival to hospital discharge. And you'll see that when we go through this literature a little bit. There are different things that they track, survival to admission, survival to discharge, things like that. But we're really looking for, who are these people that walked out of the hospital back to their family? Okay, survival to hospital discharge, as well as neurologically intact survival. You can survive a cardiac event, but due to the hypoxia of your brain, during that time, you could have neurological deficits. So that's also something that we're trying to mitigate. So the two outcomes that we're really looking at are survival to hospital discharge and neurologically intact survival. So primary cardiac arrest, secondary cardiac arrest. The first thing we need to do is differentiate. What's the difference and why does it matter? Primary cardiac arrest, that's our sudden cardiac arrest that we mentioned before as far as how we see it in the athletic training literature. That's of cardiac origin. The heart stops beating because there's something wrong with the heart, whether it's an electrical issue or a structural issue, anything like that, but the person was fine. The heart underwent an event, person not fine. Okay, so the blood is oxygenated, but not flowing. The car has gas, but the fuel pump doesn't work. Okay. Secondary cardiac arrest is of non-cardiac origin. So usually we see that due to respiratory failure. It's drowning, disease, drug overdose. That's usually when we see a secondary cardiac arrest. And that is, the blood is flowing, but there's not oxygen coming in. So it's a little bit more of a pulmonary issue at first. And then due to hypoxia of the heart over time, the heart eventually fails. And that's our secondary cardiac arrest. Very important distinction to make between the two. All right, I'm going to define a few terms. You're going to hear me say a lot of different things. And so I'm going to break those down for you here right now. One thing we see a lot is, and one thing we're looking at, because there's a lot of different literature out there about this, is out of hospital cardiac arrest. Okay, it's one thing if they arrest on a hospital bed, right? But we're talking about out of hospital cardiac arrest. That's what us athletic trainers see in the field. That's what EMS sees in the field. Okay, when we're dealing outside of the hospital. Shockable rhythm, right? Your heart can go into a lot of different rhythms when it's going through an event. And we talk a lot about shockable rhythm. That's your ventricular fibrillation, your VFib, or your VTAC. That's basically when the heart is just fasciculating in kind of a non-organized manner. You get all these little contractions, but nothing that's really efficient at pumping blood. And you see that primarily in your primary cardiac arrest. And so that's what a lot, because EMS measures these things when they get on scene, that's a lot of things that are looked at in literature because that's something that's measurable. What's their rhythm? Do they have a shockable rhythm? And then perfusion. I'm going to say perfusion over and over again. It's the most important thing. Okay, and that's the passage of blood through the circulatory system to an organ or tissue, right? It's literally the delivery of oxygen, glucose, nutrients to the tissues. Okay, so we want perfusion. People die, people have neurological deficits due to a lack of perfusion. OPA, you guys have hopefully already know this term and have learned it and practiced it in school, but that's your oral pharyngeal airway. That's a non-invasive airway. It's a little hook. It goes right in the mouth, holds the tongue up out of the way, and does not require you to stop compressions to insert. Ventilation, right? That's the act of exchanging gas in the lungs. We have positive pressure ventilation, which if you think about natural breathing is a negative pressure ventilation. Your diaphragm contracts, opens up your thoracic cavity. All of a sudden there's a negative pressure there. Air comes in, diaphragm relaxes, squeezes that cavity a little bit, creates pressure, air comes out, right? That's the natural breathing process. Positive pressure ventilation is when we use a bag valve mask or just simple mouth to mouth, and we force air into the lungs. We don't wait for a pressure gradient. We use a higher pressure in our own bodies or in a artificial valve. We force it into their lungs. Or there's passive ventilation, which is the use of supplementary oxygen. So usually that's used with an OPA. You have an airway, you strap on a non-rebreather and you insufflate. So you literally just kind of bathe the respiratory area with highly oxygenated air, but you let kind of, again, natural pressure changes, whether it's through compressions or otherwise, actually do the ventilation. So there's no forcing of air to the thoracic cavity. High quality chest compressions. If you get nothing else from this lecture, please understand how important it is that your compressions are high quality. Okay, and what do I mean by that? A lot of things go into making compressions high quality. First and foremost is hand placement. Okay, we're right at the center of the chest. We want to make sure that we're not too low, not too high, that we're right over that thoracic cavity so we can get good force through that area. Push hard, push fast. Okay, that's kind of the mantra for that. You want to make sure that you're compressing at least 2 inches in an adult and staying within 100 to 120 beats per minute. That's very, very important to getting good perfusion to your tissues. And then another thing that I feel like is kind of neglected, sometimes it's mentioned, but I feel like it's not emphasized as much as it's needed to in CPR training, is allowing full recoil. You cannot continue to squeeze an empty sponge. You have to let it refill. You have to let the heart refill before you compress it again, or you're really doing nobody any good. So making sure that we allow full recoil. Ergonomics are really important. Another thing I feel like is neglected in your average CPR research is making sure that you position your body well to be able to perform compressions for an extended period of time. Particularly if you are a smaller human and it's a little bit harder, you have a little bit less body weight to throw around, your ergonomics are going to be vital for that. Making sure you have a good base with your knees, making sure that your elbows are locked out, that you're hinging from your hips and things of that nature, very important. And then accountability. There is no room for ego in a resuscitation event, okay? Being open to and also being willing to, if someone else is doing compression, to correct them, to say, hey, I don't think you need a little bit more depth. Hey, whoa, you're pushing a little bit too fast. Having that accountability in your resuscitation team is very important. And then also being able to acknowledge, hey, you're looking like you're tired, let's switch in the next 5 or something like that, okay? Compressions are hard. And so if you can have a team and have someone to switch out with you and to have the ability to say, all right, I'm losing it, can someone come and get this? To keep your compressions as high quality as possible is very, very important. All right, none of this entire presentation matters at all if we cannot recognize cardiac arrest. If you want to watch something heartbreaking, YouTube, Zeke Upshaw, cardiac arrest. He was a G League basketball player and went into cardiac arrest in the middle of a game, and they did not recognize it as cardiac arrest. And they did not shock him until he had been down for 10 minutes. And he died 3 days later in the hospital from brain death. So that is something that is so important and so avoidable. A tragedy like that, for that reason, is avoidable. We can't guarantee that they could have resuscitated them, but we can say that when it took that long, they were not going to resuscitate him. He was not going to walk out of that hospital. So there are a couple of keys that will help you recognize cardiac arrest. First and foremost, any unexplained collapse, particularly in the athletic setting, but really in life at all, okay? Any unexplained collapse, this person was okay, and then they're not okay. It is cardiac arrest until proven otherwise, okay? If they are unresponsive and not breathing, there's an unexplained collapse, that is cardiac arrest, okay? Don't even worry about anything else. That is the number one thing that you need to be aware of. Unresponsive, okay? Hello, hello, you okay, hello? Little sternal rub, little sensations like that, stimulation, they're not responding to you, they're unresponsive. Okay, one thing to keep in mind here is a lot of times people in cardiac arrest are gonna have seizure-like twitching. That is not a sign of life. So if someone is unresponsive, twitching, not breathing normally, cardiac arrest. All right, and I've already said it 3 times in this slide, not breathing normally. It's not just not breathing. You'd be surprised, but a lot of times there is some level of what you might perceive as breathing happening when someone's in cardiac arrest. Generally, it's agonal breathing, which is a little bit more of a gasp, an occasional gasp or a snore. Sounds kind of like a snore. That is not normal breathing. It should not be considered normal breathing. The crazy catch-22 about agonal breathing is over half of people in cardiac arrest have agonal breathing, and it's actually a really good indicator that they can have a successful resuscitation. But at the same time, those have a higher percentage of being misidentified because somebody thought it was normal breathing and not going through a resuscitation protocol. So please keep in mind, agonal breathing is not normal, and it's actually considered a sign of cardiac arrest. And we actually come across it a little bit later through this presentation as well. But it's a sign that that person is still savable, that there's a really good chance that you can resuscitate them. So it's something to be aware of when you're doing your initial evaluation. Right, a little bit of the etiology of sudden cardiac arrest. Why do people go into cardiac arrest? There's a lot of different reasons. We have our structural, right? We have our HCM, or hypertrophic cardiomyopathy. We see that a lot in athletes, but we also know that it's common in athletes, so we tend to screen for that more. We have coronary artery abnormalities, and just genetics, their heart's just wired a little bit differently. There's traumatic, our commotio cordis, right? If you see someone take an impact right to the chest and then go down, that is cardiac arrest until proven otherwise, right? Okay. It's really kind of an unlucky thing. If you get trauma to the chest right in the wrong phase of the electrical phase of the heart, it'll go into VFib. So that's just something to be aware of. We have electrical problems. There's actually a whole slew of them, but the most common ones are long QT or Wolff-Parkinson-White. The most known case, I think, of Wolff-Parkinson-White would be he played for San Antonio Spurs, LaMarcus Aldridge. It's something he fought a lot in his career. They found it. He had to rest some. They were treating it. He actually played some more. He had some events. And then recently he had a more severe event. No one really talked about exactly what it was, but he was having more and more symptoms of his Wolff-Parkinson-White, and he ended up having to retire from the NBA because he said, you know what, I've had a long career, made a lot of money. I got a family now. I've got better priorities, and I'm not going to risk my life playing basketball anymore. And then a lot, more than you would think, a lot of sudden cardiac arrest cases, we don't know why they went into cardiac arrest. The only information we have is the autopsy after the fact, and their hearts are structurally normal. So we don't really know, we can't pinpoint as to why their heart suddenly went into cardiac arrest, which again is another reason why recognition and having an EAP is so important, because we'll do everything we can to prevent it, but it's really never going to be possible to completely prevent cardiac arrest. All right, now we're getting down the nuts and bolts. The physiology of cardiac arrest. So when cardiac science was evolving in the early 90s, AEDs were becoming smaller and more portable. They were getting in every ambulance. They were starting to be available in some public spaces. And they actually started to find that cardiac cardiac arrest survival was going down. And people were like, uh-oh, whoa, what's happening? And up to that point, there was a very rhythm-based intervention. Excuse me, I've totally lost my word. Thought process in the EMS and their protocols. If it was, they have this rhythm, we intervene like this and like that. And then Weisfeld and Becker got together, and they did a lot of different studies, and they looked at a lot of the data, which is really hard to sift through. I bless them, because every EMS does things different, and some things are tracked, some things are not tracked, and the data out there is just really a whole mess. But they went through a lot, and then with a lot of animal studies in the lab, they came up with these 3 phases of cardiac arrest, and they came up with a time-sensitive model, which since then has been proven with other studies. It has been proven by the fact that if you base your interventions on this model, people survive more, and things like that. So in our first phase, our electrical phase, that's from incident, from whatever happened that caused them, they went into cardiac arrest to about 4 minutes. That's considered the electrical phase. That heart is still, it's fibrillating, it's still twitching in an unorganized manner. The cardiac muscle still has a lot of oxygen to work with and a lot of glucose to work with. So it's got energy, it's just twitching in a really not helpful manner. This is why AEDs in this time are so important, because that heart is really ripe. All you gotta do is just shock it, reset it. And a lot of times that will bring them back into a perfusing rhythm. So that's why early defib is so important. But if there is no intervention and the heart is in cardiac arrest, kind of past that 4-minute mark, we get into the circulatory phase. So now the heart muscle has started to use up the available nutrients and oxygen that was available to it. So you might still get a twitch here and there, but it starts to look less and less like VFib and more just like unorganized twitching, even less organized random twitching of the heart muscle. In this phase, with the heart is in this state and you shock it, you will not get a perfusing rhythm, and you might damage the heart for any successive shocks that might come after that. So in the circulatory phase, it's very important to restore perfusion to the heart before defibrillating. And so they said, if you come at this point, there's either a delayed arrival, which again, at EMS, most of them are going to come in this kind of delayed area. And then you need to do compressions before you defibrillate. And then you get to the metabolic phase. So it's been past 10 minutes. For survival in this phase is just really, really poor, because even if you do restore perfusion, you have this global tissue ischemia, like a reperfusion injury, like we hear about with crush injuries and things like that. There's been so much tissue damage already. You start circulating the blood again, all that kind of toxic waste from that gets circulated through the body, and you have really poor outcomes from that as well. So you really don't want to let it get to the metabolic phase. Some limitations of this is it's hard to tell. There's no, just like everything in the body, there's really no cut and dry line. Okay, oh beep, it's been 4 minutes. Now they're in the circulatory phase. You know, it's a little bit of a continuum depending on the person, depending on their health, depending on previous issues, things like that. One thing you can tell that will help is people in the electrical phase, if they're going to have agonal breathing, they're going to have it in the electrical phase. So if they're still agonal breathing, then that's a good sign that they're still in the electrical phase or early circulatory phase. And you can extend these phases with intervention. So you come in and you do high quality compressions, you can expand that electrical phase, because as long, I don't know how long, you can go hours, but if you can oxygenate the heart muscle, it's perfectly fine being in VFib. It doesn't know that the rest of the body, that it's not beating properly, right? It knows it has oxygen and it's got glucose and it's just gonna keep twitching its merry life around. Okay, so if you can continue high quality compressions, you can kind of extend that time frame from which you can get a really good shock into the heart. All right, we're gonna talk about pericardial strain. This is another reason why the circulatory phase can be problematic for immediate defibrillation. So you can see here on the right here, can you see my pointer? Okay, so assuming this is what the heart looks like in a regular sinus rhythm, okay, we have our left ventricle nice and thick, it's got a lot of muscle. we have our right ventricle, it's a little bit thinner, right? We get our venous blood into the right, and our left pumps out into the body, right? So all of a sudden, the heart goes through an event, and it's not pumping properly anymore. So we're not getting any more blood really out of the left ventricle. Your arterial system has a lot of high pressure. Once all of a sudden that stops, that pressure is going to push into the venous system and then just sit. And so that causes pooling in the right ventricle of the heart, and it doesn't have quite as much muscle, so it's a little bit more stretchy. And once we get there, it starts to stretch and stretch and stretch, and it actually pushes against the pericardium and more or less strangles itself. Okay, it inhibits the circulation, excuse me, to the cardiac muscle. You shock a heart in this state, you'll get PEA, you'll get asystole, you will not get a return of a perfusing rhythm, and you might actually damage the heart to the point in which it will not receive another shock no matter what you do to it. Okay, so we give compressions. If it's a delayed arrival, we give compressions. We even out that pressure a little bit. We release the restraint on the heart. We introduce oxygen nutrients back to the cardiac muscle, and then we shock it, much, much more likely to get a perfusing rhythm. I really like this picture because it really simplifies everything in the heart. All right, so if we're talking about resuscitation, what are our two main goals? We want to maintain perfusion to cardiac and cerebral tissue. We cannot forget about the brain. Okay, very important. And restore normal cardiac rhythm, right? That's the two things we're trying to do. However we go at it, that's what we're trying to do. So, perfusion. This picture here on the left is the perfusion. It's both cerebral and cardiac perfusion. Cardiac's down here, cerebral's up in here. During 30 compressions. Okay. As you can imagine, that we have no pressure pretty much. We start compression, we have to build up that pressure. So we get this little ramp situation. But the problem with 30 compressions, we get up here to a good perfusing pressure, and then we stop. We have to give breaths. Okay. These little bumps here, these are breaths. We come over here, and we start all over again. 30 compressions, we build up that pressure. Good, 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 good. Then we're down. Okay. Over here, if we do continuous compressions, we still see that ramp. We still have to build up the pressure. Then we stay there. Okay, this is a good, viable perfusing rhythm in both the aorta, and this is the right atrium over here. So this is your venous return. You're getting some of that as well. Okay, so that's just a good visual as to what pressures and what perfusion is happening based on what your compressions are doing. So if our goal is to perfuse, we're looking at a graph like this. What are we more wanting to do, right? Okay, because every time compressions stop, perfusion stops. And every second without perfusion makes restoring cardiac rhythm and neurologically intact survival less likely. Okay, so perfusion is so important, which is why compressions are so important. And the crazy thing about this is all mid-90s, early 2000s research. They knew this. So why, when primary cardiac arrest has fully oxygenated blood, are we told to stop compressions and give ventilations? Why has that been the standard for so long? This question bugs me, keeps me up at night sometimes. Why is this a problem? Well, let's talk a little bit of a history lesson before we get back into science. So in 1924, the American Heart Association was founded. There was a couple different techniques out there that had been kind of started to be experimented with in the lab and on cadavers and hospitals and things of that nature. And at the time, there's two separate things. There's mouth to mouth, there's like you can breathe for someone, or you can compress their chest, but they were kind of two different interventions. And then in 1960, they were smushed together, called CPR, and it's been that way since then. In 1972, Seattle was the first city to have mass public training in CPR, to just really try to get that skill to the public. I have a big professional crush on the city of Seattle EMS program. They are considered the gold standard. They have a resuscitation academy. And I'll try not to fangirl over them in the literature too much, but they are pretty cool what they've been doing, and it goes all the way back to when they were first starting to train the public. In 1999, we had our first international conference on guidelines for CPR and emergency cardiac care. This was a big event. This wasn't just the Americans doing their thing, the Europeans doing their thing. People from around the world got together and said, how should we treat cardiac arrest? And it was a highly anticipated event. People were super excited about it. And then in 2000, this Guidelines 2000 came out of this event. They said, okay, this is how we should treat CPR. This is how we should teach CPR. This is what should emergency cardiac care, which is the guidelines for EMS. So what that should be, here you go. And there was a whole section of researchers and scientists and people on the ground that were like, excuse me, what? What? And there's some of the strongest language I've ever read in the literature is about this Guidelines 2000. People said it was out of date as it was written, and that they can't in good conscience follow this. They came down to, there was a bunch of animal studies done that the AHA and this conference refused to give much merit to because it was animal studies. And so they were really cutting out a really important part of the literature when they made these guidelines. And so Dr. Ewey at the University of Arizona, he was a main leader of the outcry against this and was like, he's the one that wrote, I cannot in good conscience continue to follow these guidelines. Particularly because they weren't all that much changed than what was otherwise accepted and what had been other guidelines that had come out just in America in the 90s and things like that. But there had been a poor survival rate and overall totally unchanged between 1978 when they started measuring it and 2008. Really poor survival of out-of-hospital cardiac arrest. And they had done regular updates and they had changed some of this and some of that coming out through it. Literally nothing changed, which is an overall 7.6 survival rate and a 17.7 overall with VFib with a shockable rhythm. So that is a more survivable event, but at the same time, the survival rate 17.7 is still not very good. And that had not really changed or improved with any of the updates that had come to that point. And so I can just imagine his frustration of like, this is not working. Why do we come out with this like it's some grand thing? And it's obviously not working very well. We have all this other literature. So he broke away and said, no, I have this other research. I have these animal studies. I've looked at what I can in the other data that's out there from EMS studies. And this is how I think that we should approach cardiac resuscitation. So this was his first paper he published in 2005, first paper about CCR, justifying their use of it, and really introducing the fact that they were implementing it in a few communities in Arizona and in Wisconsin, and kind of precursoring to the data that would come out from that. So there's a couple of graphics here that I want to point out to you. This one, at the time, Guidelines 2000 was a 15 compressions and 2 breaths standard. Okay, so that's what you see here. This is in swine. This is an animal study. So this is your 15 compressions. You see the ramp and 2 breaths. Now this is using the quote unquote ideal time for ventilations, which was 4 seconds. So it's 15 and 4. But then shortly after Guidelines 2000, the study came out and said, actually the average person and the trained person take at least 16 seconds to give 2 breaths. So he's like, all right, so we'll do that too. So here we have a ramp, which is much less less sharp of a ramp. And you have 16 seconds down. So you're losing pretty much all this pressure that you built. Go up and you do 15 compressions and you come down. So we can see from a perfusion standpoint how that would be problematic. This top graph over here was just a simulated lay rescue compressions only CPR in an out-of-hospital BFib. Okay, we see standard CPR gives you 13%, which is right around our normal survival rate. CCR gives us 73%. So even for accounting the fact that this was in swine, not in human, this was in a lab, not in a real life environment, still a 73% survival rate tells you something is there, right? And then this one I think is really interesting. This is survival based on perfusion pressure reached. So if the higher they got the pressure, you had more 24-hour survivors. If you couldn't get the pressure up, maybe you resuscitated them, but they died later. And if you couldn't get the pressure up at all, then you could not resuscitate them. So this is really kind of the groundwork that he laid out for CCR implementation. And so there are some observations that he made that he again used to back up his theory or his own technique that he was presenting here. So he noted that EMS, there had been actually a big study done right before he came, all this that showed that EMS was prone to compress less than half the time during a cardiac event on an out-of-hospital cardiac arrest. Okay, so everything else they were doing, everything else in their protocol, if you added everything up, less than half of it was actually compressions. Okay, so his technique delays intubation, which is the biggest delay of compressions because an invasive airway, you cannot compress and it takes some time. It's a very high level skill. Okay, so it delays intubation until you've done at least 3 rounds of 200 compressions, shock, 200 compressions. Okay, and we're compressing at a rate at 100 to 120, which right now sounds like, yeah, that's our compression rate. We're supposed to compress at 100 to 120. But at the time, the rate was up to 100 beats per minute. So it was really high for the time in which he proposed it. And then always having one responder dedicated to compression. So no matter what was going on, there was always somebody who was compressing in a team-oriented approach. He also noted studies, and we talked about this a little bit, that AEDs, when they were distributed, survival rates declined. And he used Weisfeld and Becker's 3 phases. And he said, therefore, if you have a delayed arrival to cardiac arrest or it's unwitnessed, you should do 200 compressions before using the AED. Which again, for EMS is almost every event unless something else happened to the person and then they go into cardiac arrest kind of as the secondary thing and they're standing right there. But for us, that's relevant in athletic periods because most of the time we're standing right there. He also noted the tendencies for defibrillation to lead to a period of PEA or asystole. So even if the shock was successful, there's a period of flatline before you get a perfusing rhythm. And in that period, it can actually revert back to fibrillation if it's not perfused, if the cardiac muscle is not perfused. So that's why it's really important that after you shock, you immediately get on the back on the chest with compressions. And again, at that time, it was a shock and check for rhythm before you get back to compressions. And so he said, no, screw that. We're going to shock them. We're going to get right back on the chest unless they jump up Hollywood style gasping, which most of the time they don't, right? So we shock them and we get back on the chest. And then after 200 compressions, let the AED analyze again and see if we need to shock them again. All right, and then so we have our basic protocol as far as our 200 compressions and shock, 200 compressions. And then he also broke it down into community, pre-hospital, and hospital protocols. So community is for our layperson, right? And that's basically just what we now know is quote unquote hands-only CPR, right? Really just telling them, if you see a sudden unexplained collapse, you're gonna push hard and push fast and call 911. If there's an AED there, great, use it. But it's more about the compressions. But a big key part of this as well is that he taught the community the difference between primary and secondary cardiac arrest. If you see this, an unexplained collapse, treat it like this, compressions only. If someone is drowning or an obviously respiratory distress or a drug overdose situation, or if you know it's a respiratory situation, or if it's been a long time, you don't know how long they've been down, then it's okay, we do regular CPR, things like that. He told them the difference. But community was all about recognition, just educating the community about recognizing cardiac arrest and the difference between primary and secondary, and then compressions. And their little mantra was check, call, compress. And again, also at that time, We'll get into that a little bit later, but the AHA guidelines were all about breathing and checking the breathing before it even got to compressions. And he was like, no, not that. We're going to compress first. Pre-hospital was for your EMS and utilizes a basic airway. It says, do not do an invasive airway. Initially, we do passive oxygen. And then kind of the timing of when they did some epinephrine was different as well for the EMS. There's actually a really cool aspect of this in the hospital where they use hypothermia post-resuscitation. That's beyond the scope of this lecture, but it is pretty cool. But really, no breaths. This is really what tends to hang people up. We have been taught, it's been ingrained in us. Tilt the head, open the airway, breathe. So important, compress, breathe, compress, and you tell someone, no, you don't really need that. And it can be really hard for them to grasp. But the most important fact to remember is that in primary cardiac arrest, the blood is oxygenated at the time of collapse. There is a lot of oxygen in the blood, okay? It's just not moving. We need to get it moving. There was a study that showed after 14 minutes of compression only, with no other oxygen or any other sort of ventilation happening, their pulse ox dropped to 61%, which seems low, which is kind of low, but you can get as low as about 31% and still sustain survival. They've found that in people like on Mount Everest and things have been found at high altitude. So you can go lower than that and still be okay. So 61% in resuscitation after 14 minutes without any other type of airway or anything like that is actually pretty good. But it's more than the fact that you don't really need it. It's one thing to say, you know, they have oxygen, it's okay, they don't really need it. But it may actually be, in fact, detrimental to survival due to the increase in thoracic pressures, which we'll talk about from that. And then just the very fact that you have to stop compressions in order to do it. It's a little bit of a risk reward. Do they really need it? Is it worth stopping compressions to do this? So let's break it down. Talking about thoracic pressure. So we have positive pressure ventilation, which is increased thoracic pressure. I take my air and I force it into their lungs. Okay, that increases their thoracic pressure, which decreases their venous return. Okay, there's not a lot of pressure behind venous return to the heart. So you fill the balloon, you fill the chest cavity, and all of a sudden that restricts the amount of blood flowing back to the heart. If you don't have venous return, you don't have blood in the heart. If you don't have blood in the heart, you don't have blood coming out of the heart, right? So that decreases our cardiac output. Our decreased cardiac output is decreased cardiac and cerebral perfusion. If blood's not coming out, it's not going to the brain, it's not going to the heart muscles, okay? So we really have to be careful about what we're doing with our thoracic pressures in a resuscitation event. In 2004, so it's right around this time, these German scientists released this study, and they called it death by hyperventilation. And they studied thoracic pressures during standard CPR by trained rescue personnel. So that's one thing that's crazy about this study is that these people were supposedly trained in how to use a VVM. And so you can see in this top readout here, this spike in pressure here is ventilation. These lower pressures here are compressions. And then we have a spike. Okay, so they're compressing and they're breathing. Okay, so we see that down here. You can't even tell where they're compressing because they are ventilating so much. And I'm sure if you guys have learned BVM in your classes, right, they should, if they haven't, they should talk about your rate, right? You don't need as much as you think. You don't need as fast as you think. These trained people in an emergency situation, right? You got adrenaline going on all this. They're over here, and there's no drop in pressure. There's no allow really for venous return. This is 0 right here, and it barely touches it. Okay, you can see that all in here. And this is just a breakdown. This is a smaller clip of time right here. Same concept. They're just overdoing it. So they, in this study, they found this, they read this, then they gave them some training. They cued them a little bit, like, okay, we don't need that much. Can you go slower? Remember, it needs to be like this. And so that's what we get down here. But it's still, now the breath is longer. They're giving almost too big of a breath. It's coming down here. Okay, we're going slow. And they go again. And they're still hardly ever getting past 0 and hardly ever getting there for very long. And in this study, every patient treated like this died. Okay, if you don't allow for venous return, then you cannot properly resuscitate someone. But really, no breaths. I'm telling you, people get hung up on this, and it feels really weird until you just really grasp what's going on in this cardiac event. But one of the pillars of CCR says that early intubation and active ventilation are both not needed and detrimental in primary cardiac arrest. But passive ventilation with basic airway and OPA, or something similar, there's a couple of other basic airways out there, and oxygen via non-rebreather, it doesn't interrupt compressions nor influences thoracic pressure. Okay, so we have passive oxygen insufflation. Okay, we're just blowing really rich oxygen into the airway there, and we have an airway adjunct in there to keep the airway open. Okay, so when we change the thoracic pressures with our compressions, if they're doing any sort of agonal breathing, they're pulling in really, really rich oxygen. Okay, but we're not stopping our compressions, and we're not affecting thoracic pressures at all. This is just a little bit of a graphic of things that we've already talked about. We have our community, our pre-hospital, and our hospital protocols for CCR. And then this is the EMS protocol right here, which we can really adopt to athletic training pretty well, short of the meds that they give. Okay, but they arrive, assuming, again, they come after the event. So as athletic trainers, we might have already shocked at this point, because if we're already right there, then that's something we have to keep in mind as well. All right, but we go 200 compressions, analyze, shock if it says 200 compressions again, and we go here. Okay, if you make it past this point, 200 compressions, shock, 200 compressions, 3 shocks, 4 rounds of 200. And then we start talking about, do we need an invasive airway? Are we going to need ventilation at this point? But particularly if they're still showing any sign of agonal breathing, then you can continue in this rhythm for as long as they're doing that, because that shows we're still getting blood flow to the brainstem and you're still getting this kind of gasping response. But all in all, the goal is minimally uninterrupted chest compressions. All right, here's some research for you guys. So in 2009, Bobrow et al. Retrospectively compared neurologically intact survival rates in active BVM and passive ventilation during adult out-of-hospital cardiac arrest. And you can see our passive ventilation number survival rates is significantly higher than our BVM rates as well. Again, these studies are hard, for many reasons, a lot of which you can say, okay, this particular EMS company, we're going to do this study and we're going to change our protocols like this, and this is why, and they agree and all that stuff. But we have really ingrained thought processes about emergency situations. And these people are generally highly trained professionals, and you all of a sudden change their protocol. They don't always actually change it. So there's always some discrepancies on how much protocol is actually followed. In this study, there was, they still used intubation, so they still use an invasive airway, but it's just whether or not they actively or passively ventilated. So that may have affected as well. But it did show overall higher survival rate in our passive ventilation with neurologically intact survival, to be noted, than with the black belt. In 2008, there was a study that reported survival rates of cardiac arrest with the shockable rhythm treated in Wisconsin. So the two first places that really started implementing cardiac arrest was in Arizona, where the Cerebral Heart Academy is. And then there's an EMS company. They had some sort of relationship with Dr. Ewing, and they heard he was doing the study, and they had really, really bad outcomes of cardiac arrest. And they said, hey, can we be a part of your study? We need something to change. And so they got in on that study as well. They used their control of a 3-year period with guidelines. 200 CPR had been implemented, and survival with the CCR protocol over the CPR protocol jumped from 20% to 47%. Okay, that is a huge jump when we're talking about lives. It's a huge jump when we're talking about anything. right? But we're pushing 50-50 survival. In the cardiac resuscitation world, that is amazing. That is very, very significant. And then we're talking about neurologically intact survival, that increased from 50% to 39%. So again, over a doubling of the survival rate with neurologically intact survival. These people went home to their kids and lived their life. Here's a graph from the Arizona study. This is just from, they taught statewide compression-only CPR. They didn't give it a fancy name, they didn't try to change anything, they just called it compression-only CPR. Again, they taught them kind of recognition and how to tell the difference. And the survival to hospital discharge rate over the four-year period doubled in both at a hospital cardiac arrest witnessed in shockable rhythm. So over here, this is all of them together. So we get our overall survival rate with standard CPR, which was right there. It's at 7.6 at our 30-year rate at that point. We got 7.8, right on the money. Okay, do our compression only CPR, 13.3. And this is all out of hospital cardiac arrest. So this is including secondary cardiac arrest. They got an overall improvement in survival. Okay, but we jump over to witness shockable, which is our overall more survivable rate. We get 17.7, which is right on the nose for the what had been seen up to that point. Compression only, 33.7. Again, that is a huge jump. We're talking about people's life. And one thing of note in Arizona, which I thought was really cool, is very few victims with secondary cardiac arrest received compression only. So it showed that the general public was able to identify the difference between respiratory or non-cardiac arrest and cardiac arrest. That's one of the biggest things that the AHA and other companies and other entities say, or they're like, we don't want to teach, we don't want to confuse people. We don't want to confuse the public. We give them too many terms. They can't do it. And this showed that, you know, actually they can. It's a pretty simple kind of distinction, one from the other. And if it changes their intervention, they're able to decide what it needs to be. And so that was a really interesting kind of side note from the study. Another study out of Wisconsin showed a similar survival to admission. So this is EMS got them back to the front gate of the hospital between CPR and CCR, but significant improvement of survival to discharge over CCR. So CCR is significant improvement of people, again, walking out of the hospital and going back to their lives. This one, again, there was some intubation that was still done. People are slow to change. And so that might, you know, that can affect the numbers that we see on an overall rate, an overall survival rate. But you can see here, the MICR is just minimally interrupted cardiac resuscitation, which is what they called it at the time. And you can see before and after training, the jumps that we saw in here from a 4.7 to 17.6 with witnessed BVIM. In 2012, there was a systemic review of the CCR and hands-only type of intervention. And it showed that CCR might be superior or at least similar to CPR in out-of-hospital cardiac arrest. And again, we see survival to hospital admission is very similar between the two, but survival to hospital discharge, and we see that in favor of CCR. And one thing from a community level and from a lay responder level, again, it's not just the science behind, oh, compressions and all that. People are just a lot more willing to intervene in a cardiac event if they know they don't have to do mouth to mouth. So we also get a little bit of skew of the numbers of more people actually doing it. So that's something we have to keep in mind as well. In 2012, Dr. Erie kind of detailed his protocol in a more extensive manner using the data from his studies. He emphasized the need of implementation in communities with poor rates of survival. So there are some communities where primary cardiac arrest is not an issue, where they don't see very much of that. Or there are some communities which, for one reason or another, whether it's their training or whatever they use, they have a pretty good survival rate. Maybe they don't need to change. If it ain't broke, don't fix it, right? Okay, but there are a lot of communities that have poor rates of survival, and they've just accepted it as, well, you know, it's cardiac arrest. What are you going to do? It has a poor survival rate. And he was in this article was said, no, we can, if your survival rate is less than 30%, we have shown that you can raise that by implementing this intervention. Japan, there's a really interesting study out of Japan. They began training the dispatchers and the public into chest compression only CPR. So they call that CCCPR, which I think is a mouthful, but that's beside the point. Over 6 years, CCCPR was associated with increased bystander-initiated CPR, which we talked about, and the incidence of survival with favorable neurological outcomes. So you'll see here's conventional CPR, and we see an increase in that as well. You're going to see that. You train more people, they're more comfortable in intervening, they're going to intervene more, you're going to save more people, right? So we're going to see that a little bit here. Okay, this is chest compressions only. You see a higher survival rate. And then this is any CPR whatsoever together. One interesting thing from the study is that a lot of the dispatchers still, even though they were taught and told to instruct bystanders in CCCPR, they still did regular CPR. Again, it is hard to change something that's so ingrained in people's mind as something that is what should be done. And that's what this says here. So again, the naysayers out there say, if you tell people to do chest compressions only, then the few out there that do need CPR, we're going to see a decrease in survival from them because they're not going to get what they need. And there's a few things that go into why we're not seeing this in the literature. And that's, again, the public is actually able to recognize the difference more times than not in what they need. Then also something we have to consider is that those situations that need traditional CPR have really poor survival rates anyway. So it's almost like it's hard to make it worse. And that kind of, in my mind, kind of invalidates that argument of, well, we're not showing that it's showing decreased survival rates. And in some cases, we increase it a little bit. But in the end, not many people survive that anyways because of the other type of complications in the long-term hypoxia that comes from respiratory-related cardiac arrest. There is some dissenting literature out there. There was a systemic review, or excuse me, it was a study out there out of Japan as well. And they found a significant benefit of CPR over compression-only bystander intervention for out-of-hospital cardiac arrest. But the funny thing is about this literature is they didn't really separate any type of cardiac arrest. So they had a cardiac origin or non-cardiac origin. That was the only separation. So it only really showed benefit if you break it down with this. The benefit was in young victims, which we know require more oxygen, and yet at the same time are less likely to have primary cardiac arrest and more likely to have drowning, choking, respiratory type of cardiac arrest. Okay, and then CPR was also more significant, showed significant benefit in cardiac arrest with delayed intervention of over 10 minutes, which again, we also know that, again, we have a hypoxic situation after 10 minutes. So we've got to reoxygenate a little bit if we're going to get anywhere. So it didn't really disprove anything. It kind of proved what we already knew. There was a large RCT study in 2015 that's found no difference in survival between compression only in 30-2 and out-of-hospital cardiac arrest by EMS in adults. It did not break it down between shockable and non-shockable rhythms. And both groups received positive pressure ventilation, which again, I think is an overlooked factor into survival rate in a lot of the literature. Another thing about this is there was almost 50% protocol violations. So again, every EMS system has their own protocol. So when you're trying to do an RCT in this type of environment, it's just really difficult because everyone's kind of doing their own thing. And they might be like, okay, yeah, we're gonna do this protocol. But then an emergency hits, adrenaline hits, and they default to their previous protocol or their more long-standing protocol. And so really the data in this literature is really kind of all over the place and not quite proving what it thinks it proves. since 2005. So we have been talking about early 2000s, like okay, great, for 20 years later, surely they've made some changes. So let's talk about how the AHA has changed since then. So in 2005, AHA was like, okay, 2000s, maybe it was not quite what we wanted. So our bystander CPR is going to be 30 to 2, increase from 15 to 2. Okay, so compression's okay, maybe kind of important, but if you have 2 people doing CPR, definitely still do 15 to 2, which is never something that I've never understood that even before I knew what CCR was. But we've got 2 people, let's go to 15 to 2 still. They did say compressions, high quality compressions were important, but at approximately 100 beats a minute. They reduced AED shocks from 3 to 1 at a time, and that was another big contention with guidelines 2000. Up to that point, everyone's like, they need a shock, you shock them 3 times in a row, boom, 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 with an AED. And that had already been proven to be really not effective, and they still recommended that in 2000. So in 2005, they said, okay, we're 1 at a time, and then we do 5 rounds of CPR, and then we analyze again. So they kind of got it right there. For EMS, for ECC, they still suggested or still recommended the advanced airway, active ventilation, and you can do continuous compressions if you have a tube in, and 30 to 2 if you don't have an advanced airway. But they kept ABC, right? If you're old enough, which I'll go too young, you're probably born in 2005, I'm so old, but it used to be, they tell us ABC, check the airway, check the breathing, work with that, clear it, airway, and they would go to compressions. And they kept that thing. So it was still a long, could be several minutes before people actually started compressing in a cardiac event. In 2008, not a full update, but the AHA kind of started to leak out this hands-only type of campaign, basically just, and it wasn't even really having to do too much with Dr. Avy's literature. It was more of people are not doing CPR. How do we get them to do CPR? Tell them that they don't have to do mouth to mouth, at least do compressions. And so they kind of introduced that campaign, and they did see an increase in bystander CPR, so that was good. Finally, 2010, they changed it to CAB, compressions, airway breathing. That's probably more what you guys are used to seeing. So at least they said, okay, you come to a scene, you recognize this cardiac arrest, give them compressions, and then check their airway. Okay, we're almost there. They're starting to figure it out. They still have the rate of at least 100 compressions a minute. We're still a little slow there, but we're getting there. And at least 2 inches in depth, which is good. Hands only at minimum, but if you're trained, stop and do breaths. They did differentiate between trained and untrained lay people. And they finally emphasized the recognition of agonal breathing and what we call myoclonic twitching, which is that seizure-like twitching that you'll see. Okay, so they started to emphasize recognition a little bit more because they realized people were not recognizing what was going on. In 2015 was the first time they gave a nod to CCR. They say, quote unquote, may be reasonable for an EMS system, priority-based multi-tier response to delay positive pressure ventilation by using a strategy of up to 3 cycles of 200 continuous compressions with passive oxygen instillation. So this was kind of a big deal, honestly, for them to even recognize that there was another way of doing things out there and that it, quote unquote, may be reasonable for people to do it. But outside of that, the 2015 update was really not a whole lot of an update, except it went away from 15 to 2 overall for adults. And finally went to that 100 to 120 compressions a minute. And then in 2020's most recent guidelines, it's still, they do not address the difference between primary and secondary cardiac arrest. And that's probably my biggest frustration with the AHA, is that we have shown that people can tell the difference and that the difference matters. So why can't we address that? But it suggests that trained lay people do CPR in all cardiac arrests, but it does say compression only is a reasonable alternative if they don't feel like they can do it, or they don't feel trained enough. Then it's reasonable. And then with EMS, it says a minimally interrupted cardiac protocol is a reasonable alternative, but it doesn't give details like in 2015. And again, it's kind of like, okay, this is what we want you to do, but there's like this other thing over there. You could do that too, that's okay, but this is what we want you to do. So they really don't give a lot of any of that details. So here's just a breakdown of Guidelines 2000. What came out was the straw that kind of broke the camel's back over here, what CCR says, and then what our current guidelines say. So for 2000, a population is really any unresponsive person who's not breathing normally with no pulse. Side note, pulse checks. We haven't really talked about that. Depends on who you talk to. CCR, most of the literature that I've read and the paramedics that I've talked to and trained with, we don't worry about pulse checks. Pulse checks take up time and is notoriously inaccurate. People tend to feel their own adrenaline pumping through their veins and they can't feel a pulse. So, or they think they feel a pulse and it's not really a pulse. So if you're gonna check pulse, we're not gonna get into that discussion too deep right now. If you're gonna check a pulse, check the pulse, but do not take a long time with it. And if you are not 100% sure that you are feeling a strong pulse of the other person under your fingers, then you assume that it is cardiac arrest. So that one was for free. That's a little side note there about pulse. CCR is for out of hospital events with shockable rhythm, or of course we don't always know what a rhythm is, right? We don't have a machine with us generally as athletic trainers. So if it's a witnessed unexplained collapse, they're unresponsive, that abnormal breathing, that should trigger CCR if that is your protocol. And again, in 2020 AHA, again, that's our any person who might be having cardiac arrest for any reason. That's our population. 2000, we talked about that, 2 and 15. 2020, we're back here with 2 and 30. Or if you haven't, for an EMS, if you have an airway established, you can do 10 breaths a minute with continuous compressions, but always positive pressure ventilations. For CCR, we're no ventilations. If you don't have that available to you, it's acceptable to not do it. But if you do, you should drop an OPA and have a passive oxygen on it. Okay, we have 200 compressions. AHA is our 30. Our initial EMS airway is always a basic, whether it's an OPA or another basic type airway adjunct. Okay, and for an EMS, again, AHA is always saying they should drop an advanced airway. And then 1 shock after every 200 compressions as indicated, which is about the same as every 2 minutes. Again, you're not going to get 200 compressions in 2 minutes if you're stopping to get breaths, but the time frame is about the same as far as with AHA. So all that, what did I actually really say? So there was a study that came out that showed survival of patients without a hospital VFib in US and Europe versus with CPR, which is what we see in green, and cerebral resuscitation, which is what we see in red. These 2 black lines over here is, again, historically what they had seen up to that point. These are major cities and what they had seen. This is the average with the 2005 guidelines. We see this here. Again, professional crush on Seattle. They don't do true CPR or true CCR. They can intubate someone and not stop compressions, which I read one of these studies was like, Seattle does this and that's not normal and no one else can do that. So that doesn't count. I was like, what? Again, they have higher numbers because they are very, very good at what they do. And then over here, we have CCR. The red is neurologically intact survival and the yellow tabs are if they had a little bit of neurological deficit. But this is survival. And you can see how in percentage, and you can just see how big the difference is and how significant the difference is. And again, we're talking lives, percentage of lives, not just lives. These red bars, these are people, again, walking out of the hospital back to their family, living their life. So cerebral resuscitation is more effective at achieving survival of adult primary cardiac arrest than standard CPR and should be considered by athletic trainers for implementation in cardiac emergency action plans. Okay, CCR is a very specific intervention for a very specific population, but that population is our population. Okay, there is discussion where there has to be some consideration if you're in a secondary school Where are they? Are they pubescent? Are they adolescent? Are they children? But again, is it primary cardiac arrest? At that point, I would say it doesn't really matter. Most of the, particularly in our adolescent kind of age, most of the issues when we get cardiac arrest in young people is the choking or drowning issue. And that's a whole different issue. Okay, when we're talking about our population that we're going to see for your traditional athletic trainer, this is this population, right? We got adult people with primary cardiac arrest. That's what we see. So why aren't we doing this? What are some barriers to CCR? Besides the fact, biggest barrier to athletic training, I feel like, is people don't know about it. So I don't have that on there, but that's a big one. And I said, that's something I can fix. Let's see if we can spread the word. But some other barriers, again, we've touched on this a couple of times, is ingrained habits and beliefs about resuscitation. You know, you're taught as a little child, you've seen pictures, maybe you've been to classes, maybe your parents trained you, you watch TV, Grey's Anatomy, right? There are different beliefs that you have about resuscitation ingrained in your brain, and it can be really, really hard to let those go if they're wrong, even if they're wrong. You don't have to breathe for somebody if they have oxygen in their blood. Seems simple, but it can be hard to let go of, particularly in people that are already trained. It's one thing to train people up that don't know, but people that have been trained for a while, it can be a little bit of an issue. Hesitancy to use OPA and oxygen. You guys are blessed to be young, and KD standards now and what's required of you guys gotta learn OPA, and you gotta learn how to use an oxygen tank and things like that. I work with, and I have seen, and I have had conversations with athletic trainers that are not comfortable with either of those things. And honestly, it kind of breaks my heart. Neither of them are very hard. Honestly, they're not very complex skills. And in my mind, it can save a life. But there is hesitancy in the athletic training population, the older athletic training population, more so, to use an OPA and to use oxygen. But when we're talking about simplicity of an OPA, there in Japan, they're talking about adding OPAs to their AEDs, to their AED packets, because it's so simple. The public can follow basic instructions and put it in. They can have basic training and do that. So really, when people are hesitant, I use that example. I said, they're talking about letting the regular Joe Blow on the street drop an OPA. It's not hard. It's not hard. And then awareness about recognition of primary out-of-hospital cardiac arrest. Well, okay, this is something I'm supposed to do for primary cardiac arrest, but what if it's not primary cardiac arrest? Oh my gosh, oh my gosh, oh my gosh. And we've shown it's at least the same as CPR in most cases, right? If you didn't see this person drown, you didn't see this person choke, you don't assume it's a drug overdose or some sort of respiratory failure, which has really poor survival rates anyways. You can treat it with hands only, you can treat it with CCR, and you're gonna get a more favorable response, more likely, okay? Again, breaking it down, the general public can tell the difference, us as healthcare professionals can tell the difference. So as athletic trainers, what do I do? What does that look like? Obviously, we have a high likelihood that we're gonna be right there with an AED, okay? So if you can recognize, prep the chest, and apply the AED in less than 4 minutes, whatever compressions you're doing in the interim while you're applying the AED is enough. You don't have to go all the way to 200. You're right there in that sweet spot. Shock that heart when it's ready, okay? If it's a longer prep or delayed, then somebody calls you out somewhere, oh my gosh, I don't have the AED with me, someone's gotta go get it. Make sure you get your full 200 in before you defib them, okay? And then if you've got it, use it. Drop your OPA, strap on a non-rebreather, and do not stop compressing except to shock them. Compress, shock, till you get obvious signs of life, or EMS comes and tells you to stop, right? EMS might come and say, hey, your compressions look great. Keep doing that. We're gonna drop a line. Let us know. We'll change here in a second. Some other important things to do, no matter what your protocol is, but meet with your local EMS. What is their protocol? How are we going to complement them? If I'm doing this when they show up, what do they want me to do? What are they gonna do? How do we work together? Okay, that's really, really important. Discuss CCR with your medical director and consider adding it as an EAP. There's a lot of literature out there. If you want it, I'd be happy to send it to you. I think it makes a pretty good case, and the numbers are really good. Talk to your directors about that and say, can we add this into our EAP? Train with OPA, no two, that should be comfortable to use. If you don't have oxygen, some settings you might not. That's okay, you can put an airway in. You're still gonna get a little bit of gas exchange between your compressions. They're doing agonal breathing. They still do not need initial active ventilation, okay? And then drill. Once every 2 years is not enough. I would argue to say once every year is not enough, okay? If high quality compressions are important, you need to be able to keep your compressions high quality. Okay, if you're gonna have a team-oriented response, if you have you and students, if you are students, if you have you and coaches, whatever your setting may be, okay, who's gonna do what? I feel like Wade did a really good job of this when I worked with him on Abilene. Okay, this was this person's job, this was this person's job. We switched at this number of compressions and the next person was ready. We're on opposite sides of the body, so we're not on each other's way. This person's done, we go this side, the next person goes on to the next thing that they're supposed to do, okay? If you have the capability, if you have the bodies, if you have the trained personnel, even untrained personnel can be helpful. Drill a team-oriented cardiac response, no matter what protocol you're using. It's so important. And again, whether you think what I just said was hogwash or you think it's great, okay, whatever protocol you use, these keys are universal. You have to know the signs of cardiac arrest. You have to be able to recognize it. We cannot treat what we do not recognize, okay? Keep your compressions high quality. If you've got trained people around, even if they're coaches, even if they're otherwise, if you're getting tired, your compressions are useless, switch, okay? Minimize your interruptions. That's what the practice and the drilling, the training comes through. How can we get what we need done without stopping compressions? Okay, we shock, we get back on the heart before the machine even says get back on the heart. It takes this long to send an AED shot back on the body. Okay, compressing. If you do ventilate with BVM, if that is your protocol, if that is what your medical director wants you to do, you better not hyperventilate. You better err on the side of underventilating, okay, because you will kill somebody by hyperventilating. That has been proven. Okay, so just be very careful with a BVM if that's what you're doing. People's lungs are not as big as you think it is. All right, in conclusion, CCR is not a replacement for CPR, but a bundle of specific and effective therapies that target a specific population, okay? Population, then we talk about cardiac emergencies, that is what athletic trainers encounter most frequently. And athletic trainers possess the skills and knowledge to effectively implement CCR and cardiac EAPs, and don't let anyone tell you otherwise. And that's it. That's my talk. Oh, don't share. Stop sharing.
All right. Grace, thank you so much. I know that this was a lot of information, but you know, as you guys can obviously see, this is crazy important. And you know, like Grace said, regardless of what you think about what was presented, right? We learned some key fundamentals, which is the recognition of the true toxic cardiac arrest, right? And it's so important to know, but I'm not going to steal Grace's thunder.
I just want to know if you guys have questions. This is something I'm really passionate about, and I will not keep you here. I'm in Mountain Time Zone. It's only 7:50 here. Let's go. But I'm happy to answer any of your questions right now. Wade has all my contact information if you want to reach out. But does anybody have any questions? Did I blow through anything? Do you want me to clarify anything?
I just think this was really valuable, and I really liked this talk. So thank you so much.
That makes me so happy. I will tell you, like I said, you get me talking about things I'm passionate about, I'm going to talk. But I really have, as a practicing athletic trainer, I have no time for lectures that are not relevant to my life. They will not help me practice. So I love when people say, you just talked to me for an hour and I got something out of it. That's my goal. So thank you. and I hope that you can take this into your practice.
Yeah. Well, guys,
so like this is something we could apply tomorrow.
Yeah.
Like
yeah.
engage with someone.
Yeah, somebody goes down tomorrow, you can do this.
Yeah.
We just have to unmarry our minds to the fact that we think people need ventilation in primary cardiac arrest, and they just really don't.
And absolutely. And this is something we could eventually draw on, depending on, being able to kind of talk to more people like within the topic, and kind of getting a little bit more buy-in. This is something that can very easily be drilled on amongst all of us. Very easily.
Sure. Yeah.
Watch this.
Yeah, for me, one thing I was frustrated about was, okay, I've been taught CPR for this long. Why didn't nobody tell me what was going on in the heart? Why didn't nobody tell me the physiology of it? Because then it makes sense. And when somebody tells me CCR, then this makes more sense. But that didn't really click until I learned the physiology. So whenever I'm teaching CPR, again, I try not to make my CPR class 3 days long talking about this stuff. But at the same time, I want people to understand the anatomy and the physiology and what's going on in the cardiac event. Because then you can make your own informed decisions about what is best for your patient population.
Yeah, I think that helped me understand it more because blood has oxygen in it. So why would you need to get ventilation?
Exactly. Exactly. So, like I said, there's a lot of literature out here with this. So if you want, Dr. Erie since then has published several articles that just kind of overview everything, his study and what he's done to that point and things like that. If you ever want any of those resources, I can always send those out.
Any more questions? No? Okay. Guys, thank you for coming. I know that Grace really appreciates it. I do too. And so I'm glad that this was a really positive experience. Thanks for having me. And yeah.
Thanks for having me, boss man.
Oh, stop it. Stop it. You're gonna make me blush. All right. It was really good to see you.
Thank you.
Yeah, for sure.
Thank you.
And I promise I am writing. I'll get it to you. I am writing.
It's okay. Fine.
I'm writing this up for athletic trainers, and Wade keeps asking for a draft that I don't have yet. But I am working on it.
Okay. I will, trust me, it's almost summer and I will actually have time, potentially.
Same.
All right.
Okay.
All right.
Bye-bye.
Talk to you later. Bye.
Yeah.